In this presentation, we will cover the main symptoms of ischemic heart disease, and we will explore together the process of atherogenesis at the cellular level. Let's begin with the clinical manifestation of ischemic heart disease. Often, there are no symptoms of the underlying disease of the blood vessels. A heart attack may be the first sign of underlying disease. Symptoms of a heart attack include pain or discomfort in the center of the chest, pain or discomfort in the arms, the left shoulder, elbows, jaw, or back, difficulty in breathing or shortness of breath, nausea or vomiting, lightheadedness or faintness, cold sweat, turning pale. The dynamic nature of the CAD process results in various clinical presentations, which can be conveniently categorized as either acute coronary syndromes or chronic coronary syndromes. The atherosclerotic plaque accumulation is a progressive process, hence ischemic heart disease is chronic, most often progressive, and thus serious, even in clinically apparently silent periods. Let's explore the pathophysiology of coronary atherosclerosis. For this purpose, we must return to the coronary arteries and deep dive again. Only this time, we will closely observe the pathological processes taking place at the cellular level. This will allow us to better understand how risk factors facilitate the progression of atherosclerosis. Thus, we will focus only on the endothelial layer, the tunica intima, and on a small portion of the tunica media, and observe the atherogenic process. The trigger of atherosclerosis is usually the hemodynamic stress induced by the blood turbulences or high blood pressure on the endothelial wall. This will cause endothelial damage, which will increase both the adherence of the endothelial surface and the permeability of the endothelium, leading to the infiltration of LDL cholesterol particles. LDL cholesterol particles will start to accumulate in the tunica intima, and the presence of free radicals produced by oxidative stress will turn them into oxidized LDL cholesterol. Monocytes will also adhere on the surface of the endothelium and infiltrate into the tunica intima, triggering the expression of adherence molecules. The increased adherence of the endothelium combined with the endothelial injury will attract more and more monocytes. Stimulated by the oxidized LDL cholesterol, some monocytes will differentiate into M2 macrophages. The M2 macrophage has a special toll-like receptor which will allow the detection and ingurgitation of oxidized LDL. However, the macrophage is incapable of digesting the LDL particles, and because of this, it will die, turning into a foam cell. Foam cells will induce vasoconstriction via the suppression of endothelial nitric oxide synthesis. In the meantime, other monocytes will turn into M1 macrophages secreting pro-inflammatory cytokines which will attract more monocytes. This creates a vicious circle, inducing both the accumulation of foam cells as well as increased synthesis of pro-inflammatory cytokines. All those factors combined will lead to the growth of the atherosclerotic plaque. The presence of foam cells destabilize the plaque, so the more foam cells are present, the more unstable the plaque becomes. Vascular smooth muscle cells will start to migrate from the media to the top of the plaque, forming the fibrous cap. Necrosis will start to develop, inducing the activation of metalloproteinases which will erode the fibrous cap, destabilizing the plaque and leading to plaque rupture. The exposure of the lipid core will activate the coagulation cascade and the formation of the blood clot, leading to the thromboembolic event.